ครับสวัสดีครับผมนายแพทย์ณัฐวุฒิ วานันค้างจักษุแพทย์ประจำหน้าตาจักษุคลินิกนะครับวันนี้ผมได้มีคลิปวิดีโอที่ผมได้มีโอกาสไปบรรยายเรื่องการผ่าตัดแก้ไขท่อน้ำตาอุดตันด้วยวิธีส่องกล้องนะครับที่ประเทศเนปาลเป็นการจัดประชุม Virtual Meeting โดย Nepalese Society สำหรับ Oculoplastic Surgeon นะฮะในหัวข้อที่เรียกว่า Highway of Tear นะฮะซึ่งการประชุมเนี้ยจัดวันที่ 17 กรกฎาคมนะฮะ2564 นี่เองนะฮะเป็นการประชุมใน region ของเอเชียแปซิฟิกซึ่งมีเพื่อนผมคือดรเบนลินพูเนี่ยเป็น President ของ Nepalese Society ของ Oculoplasty Surgeon แล้วก็มี Professor จากหลายประเทศนะครับlocal professor ก็ได้แก่ดร professor โลหิตไซจูเป็นเพื่อนผมแล้วก็เป็นหัวหน้าแผนก oculoplastic ที่ทิวกังกาแล้วก็มี professor เลนาโดพาวเต้ซึ่งเป็นอาจารย์ที่เป็นมือหนึ่งของฟิลิปปินส์นะครับซึ่งให้เกียรติมาบรรยายในงานนี้ด้วยแล้วก็มีดรอาเชซึ่งเป็นinternational speaker จากประเทศอินเดียก็มาร่วมด้วยนะครับในหัวข้อของการประชุมของในครั้งนี้เนี่ยนะฮะผมก็จะพูดเรื่องการผ่าตัดendoscopic DCR โดยเป็นการแชร์ประสบการณ์ที่ผมได้ผ่าตัดฟิลนี้มาประมาณ18 ปีได้อาจจะมีทริคบางอย่างที่เป็นทริคเล็กทริคน้อยที่แล้วก็เป็นคอนเซ็ปต์นะครับซึ่งเกี่ยวกับเรื่องคอนเซ็ปต์ของกระดูกแล้วก็โบนที่จะมาสามารถแอพพลายใช้ในการผ่าตัดแก้ไขท่อน้ำตาอุดตันด้วยวิธีส่องกล้องได้อันนี้ก็จะเหมาะสำหรับคุณหมอตาหรือคุณหมอจักษุแพทย์ที่สนใจทางด้านออคูโลพลาสติกซึ่งกำลังเริ่มที่จะผ่าตัดลักษณะนี้นะครับแล้วก็ในการบรรยายวันนี้เนี่ยจะเป็นภาษาอังกฤษนะฮะซึ่งเอาไว้ถ้าว่างๆเนี่ยผมจะทำเป็นการบรรยายภาษาไทยเพื่อให้เข้าใจง่ายด้วยนะครับถ้าเข้าไปถึงหัวข้อของการประชุมในครั้งนี้นะครับก็จะมีเขาตั้งชื่อว่าเป็น Highway of Tear ก็จะสรุปรวบรวมปัญหาต่างๆเกี่ยวกับเรื่องน้ำตานี่แหละโดย mainly ก็จะโฟกัสไว้ที่ปัญหาน้ำตาไหลออกมาเยอะน้ำตาไหลเรื้อรังที่เกิดจากสาเหตุของท่อน้ำตาอุดตันนะฮะเราก็จะไล่เรียงตั้งแต่การผ่าตัดโดยใช้กล้องส่องที่ไม่มีแผลการผ่าตัดโดยใช้เขาเรียกว่า transcanalicular นะครับ decanalization ของท่อน้ำตาส่วนล่างที่อุดตันนะฮะแล้วก็มีการผ่าตัดท่อน้ำตาอุดตันโดยมีจากแผลทางด้านนอกหรือเราเรียกว่า external Dcr นะฮะก็จะมีด็อกเตอร์จากประเทศดรซาอีจากประเทศบังกลาเทศก็มาด้วยนะครับแล้วก็ท้ายสุดหลังจากที่ทุกๆคนเนี่ยบรรยายนะฮะก็จะมีการ discussion จาก panelist ตรงพาร์ทของ discussion จาก panelist เนี่ยเป็น point ที่น่าสนใจที่สำคัญแล้วก็จะใช้เป็นทริคนะฮะในการเสริมทำให้การรักษาของโรคตรงเนี้ยมันดีขึ้นได้นะครับแล้วก็ถ้าเกิดสมมุติท่านใดที่สนใจนะฮะอยากฟัง full course ของmeeting อันนี้เนี่ยก็สามารถที่จะไปเปิดดูใน YouTube ได้นะครับโดยเซิร์ชคำว่า NESOS 2021เนปาลอันนี้ก็จะลิงก์อันนี้ก็จะขึ้นมาเลยความยาวนี่จะประมาณ3 ชั่วโมงครึ่งนะครับถ้าใครเป็นบิ๊กแฟนสำหรับเรื่องการผ่าตัด endoscopic DCR อันนี้ก็ไม่น่าพลาดและพลาดไม่ควรพลาดด้วยนะครับนะฮะเต็มโปรแกรมเนี่ยของการผ่าตัดก็จะประมาณนี้ก็จะไล่เรียงไปนะครับตั้งแต่ endo DCR external DCR transcanalicular micro endoscope decanalization แล้วก็ external DCR แล้วก็ fail DCR แล้วก็จะมีการพูดถึงnational survey DCR ของประเทศเนปาลด้วยนะฮะนี้เราก็จะไปถึงพาร์ทของวิดีโอที่ผมได้มีโอกาสผมตัดมาให้เป็นคลิปสั้นๆนะครับเฉพาะของผมเองซึ่งบรรยายเป็นภาษาอังกฤษ
is the Assistant Chairperson Director of Oculoplastic Fellowship Program, Department of Ophthalmology, Bumrunghad International Hospital, Bangkok, Thailand. He was former Program Director of Residency Plastic Fellowship Program at Meta Pracharak Eye Institute, Medical Services, Ministry of Public Health from the year 2004 to 2008. He is also Director of Eye Clinic. Dr. Nataud has received numerous prestigious awards, including Outstanding Doctor Award from Medical Services, Ministry of Public Health, Thailand in the year 2012, and achieved APAO Achievement Award in the year 2017. He has given several lectures in both national as well as international platform and has several books published and more than 50 scientific research publications in internationally peer-reviewed journal. We are very honored to have you here today, Dr. Nataud.
As earlier said, Dr. Nataud is a plastic and reconstructive specialist, and he is the Assistant Chairperson and Director of Oculoplastic Fellowship Program in Bumrunghad International Hospital, Thailand. He is also Director of Eye Clinic. Dr. Nataud, the screen is yours.
Hello, good evening, everyone. I'm so glad to have the opportunity to share my concept for the endoscopic DCR today. And today, I would like to share about the two concepts for approach that I have used for my endoscopic DCR. The first one is the bony concept, and for the how to get the adequacy of the bony osteum. And second is a flap concept that I have applied and used for the flap design and try to approximation with the suturing technique. Okay, this is the good video show the 3 dimension of the normal and the ideal bony osteum on the right hand side. And if you have used Apple, you can use download the Anatomy C application and try to learn the relationship of the important bone. Now, the 4 of the important bone that we need to be familiar and the understanding. The first one is the frontal fossa of the maxillary bone. We need to know the relationship of the surface anatomy and the surrounding soft tissue surrounding the bone, the nasolacrimal duct, and the thickness of the frontal fossa of the maxillary bone. Second is the lacrimal bone, especially on the anterior half of the lacrimal bone. And the third one is the ethmoid bone, especially the medial aspect of the lacrimal drainage unit. And especially sometimes occasionally we have to deal with the inferior concha bone. That is the drainage pathway by the distal part. If we know the relationship very good between the soft tissue and the bony tissue, we can deal very good during the operation. If you are the beginner, you can buy the application and you can try to do the digital endoscopic dissection. First, removal on the lower 2/3 and upper 1/3, and then try to remove the lacrimal bone, and then try to evaluate how good you have done by the orbital view. And sometimes you have to deal with the actinic cell or the uncinate process medially. So let's go to the real surgical video. First one, we start to remove the C-shaped flap and try to remove the lower 2/3 with the simple horizontal rongeur. In my practice, I don't use a drill. I use a simple rongeur because it's cheap and fast, and try to remove the nasal mucosa conservatively and remove the bone to get the adequate nasal ostium. At this step, try not to remove the nasal mucosa too much because you have to leave the bare bone, and that gonna leading to the secondary intention healing. The next step,
we deal with the upper 1/3 of the frontal process of the maxillary bone. This is more challenging because sometimes if the nasal cavity is big enough, it's easy. But if the nasal cavity is so narrow from the septal deviation, sometimes we have the difficult time because the space is limited. And the one of the trick that to remove the bone, we should remove about 3 to 5 millimeter above the common canaliculi. This is the point that we're gonna get the adequacy of the bone that we have removed. The next concept that I always use to apply to during the operation, if we have the concept in mind that how many type of the classification that we can use, we can adjust and choose the appropriate. In my practice, I have started to use flap suturing since 2006. And nowadays, I have in 100% of my case, I try to remove. And the ideal suturing and the ideal suture material is 6OYQ. On the upper part is S22 needle is ideal needle because it's a spatula needle, and the length of the needle is 8 millimeter, and the curve is 180 degree. If you don't have the S22 and if you have only S14 or the 90 degree needle, you can use your needle holder to bend from 190 degree to be the 180 degree, because the 180 degree can work really good in the very narrow cavity. For the flap suturing classification, I try to divide to be 4 classification, and I will start the step by step. The first one, the most common one that I always use, and most of my case, about 95% plus, I have used anterior and the posterior flap. This is a diagram show that when we have removed the nasal mucosa and the bone in the adequate bony anatomy, we make the I-shaped incision to create the anterior and the posterior flap. And in the video, you can see that I try to suture the upper half of the anterior flap and try to use a two-hand technique with my assistant sit in the opposite side and hold the endoscope. The technique to hold the endoscope, we should locate the endoscope in the infromedial of the part of the nasal cavity that allow the surgeon to have the adequate space to work, and the surgeon can use a two-hand technique and try to introduce the notch gradually from the outside to inside. And from the video, if you have time and you want to make sure that the flap is so good, you can try to make the posterior flap suturing. But anterior flap suturing is much more easier because more space, and you can work, but the posterior more challenging because of the a little bit too deeper, and sometimes we have no adequate of the nasal mucosa posteriorly. But in my practice, most of the time, more than 95%, I do only the anterior flap suturing. The second classification is superior and the inferior flap. In this flap, can be applied, but I use only 3 to 5% of my practice. And the lacrimal sac that get distended from the chronic dacryocystitis or acute dacryocystitis, we can use this technique to apply. But in some difficult condition, I use a superior flap to optimize the surgical success. And on the left-hand side, you can see that we can create the head-shaped incision. And from the video, on the inferior flap can be suture also, but most of the time, the inferior flap can drop it by the gravity. And the third one is a combined flap. This is a combination between the superior and the anterior flap. And this technique, most of the time I use for the when I do the revision surgery. I'm gonna show you. And lastly, the isolated flap. This is a good video that shows the step of the mechanism of the some syndrome that I think I have seen this one. Let me show you by the video. And this is a picture of the when the surgeon removed too much of the nasal mucosa, and the bony part have open in the small opening. And when we put the stent and keep for a while, the scar tissue encroaching from the upper part and the lower part, like and then even though we put the silicone stent, after remove the stent, the scar tissue come out, and sometimes they have the small opening we call the sum syndrome. But sometimes the scar tissue cover for the whole part, and they have the thick scar tissue. In this case, we can apply the isolated flap for correcting the sum syndrome. And okay, and this is a video that show the patient that have on the right side and have the really tiny opening. When we try to irrigate that, and the water could be flow, but the patient have the symptom have a lot of excessive tear. When we do the evaluation, when we make the vertical cut, you can see that the internal mucosa is still healthy. In this case, we can try to apply the anterior flap or apply the posterior flap with this one simple isolated flap. Sometimes we can manage this one in the office. We have no need to bring the patient to the operation room. If you have the endoscope in your office, you can just the patient lie down, inject some numbing medication, and use a tiny 15 blade and make a vertical cut. And then with the one simple suturing, we can correcting this one easier. But we need to make sure that the internal lacrimal mucosa is so healthy. The next one I'm gonna show the how the inadequate bony ostium lead to the failed DCR, and how we approach by the endoscopically. This is a video show how to, if the surgeon do the external DCR, and when we perform the external DCR, sometimes we can remove the bone in the limited area, and the area of the bone removed underneath the medial canthal ligament gonna be quite difficult. If we use an endoscope to examine intranasally, we can see that sometimes they have the limited space. And on the left-hand side, show the diagram that show the fail from the endoscopic DCR. And you can see on the red area that they have the very thick scar tissue, mostly on the nasal side. That because of the endoscopic approach that remove the nasal mucosa too much. On the right-hand side, you can see the scar tissue a lot on the on the lacrimal side. By the step of the scar tissue that previously I have tried to think about the mechanism. When we put the silicone stent, and when we remove the stent, the scar tissue encroaching to be the thick scar tissue, and then completely obstruction happen. And sometimes the very thick scar tissue happen, and sometimes the nasal mucosa have been disturbed so much on the lacrimal mucosa. Sometimes it leading to the very thick scar tissue, including the common canalicular area. In this condition, it's going to be quite tough when we try to revision this one. By the endoscopic benefit, we can use the endoscope and try to remove the upper 1/3 of the bone. If in this case, we try to expose to the whole wheel of the medial side of the lacrimal drainage system. In this video show on the left-hand side, the patient that have the very fell from the previous endoscope DCR surgery. And when we make the C-shaped flap, it's not that easy. We can see the very thick scar tissue. And in this case, we have found that the upper 1/3 of the frontal process of the maxillary bone have not been removed properly. So we can remove step by step by the chisel and the mallet. And this step, after removal of the upper 1/3, we have seen that on the area of the common canaliculi, they have the very, very thick scar. In this step, I try to make the horizontal cut and try to use a second instrument, try to create and try to, even though you have the limited area of the residual mucosa, sometimes the scar tissue, we can make the vertical cut or the horizontal cut and try to make the scar tissue imitate like a pseudo flap. And in this case, I try to make the scar tissue imitate like a superior flap and try to use backhand suturing and try to make the suturing to the superior pseudo flap to the nasal mucosa superiorly. And in this case, if we don't do the suturing, sometimes the scar tissue that like a superior flap can be flipped inferiorly and can make the scar tissue really recurrent of the sick scar tissue on the area of the common canaliculi. In this case, I think the benefit from the apply on the superior flap suturing can help in the difficult condition. And then put the silicone stent and put the MMC or put the steroid injection gonna help. By conclusion, if we have the two concepts by the bone concept and the flap concept, we can keep in mind and we can choose any type of the classification to apply for any kind of the endoscopic surgery. Thank you.
Hello, Dr. Nisa, are you there?
Yeah, I'm here. It was muted, sorry. So thank you, Dr. Nathod, for sharing your experiences. It was a wonderful and interesting talk. And I would now like to request Professor Dr. Havati to add few comments on this presentation.
Yeah, thank you very much for inviting me here to this webinar. First of all, I would like to congratulate Nathod for that outstanding presentation. You know, I remember when I was doing endoscopic radiofrequency assisted DCR, I also don't use the, these drills and then, the powered instrumentation, especially now in these COVID times, wherein it's very easy to produce aerosolization of these viruses. And I've seen in your, in your presentation that you also utilize the Kerrison punch just to remove the anterior 1/3 of the frontal process of the maxilla. And I also admire your technique of suturing the, the flaps. Actually, very few surgeons can do that. But with your technique and of course, using the proper needles and, and everything, including the suturing forceps, you were able to do so. Now, my comment is the one thing that I find difficulty in endonasal DCR is, of course, in cases of cicatrice, lacrimal sac, and of course, patients who have, what we call a septal deviation, wherein you really have to do septoplasty before the procedure. Now, we know very well that the success, whether you are doing intranasal or endonasal, or whether you are doing external DCR, it is the wide marsupialization of the lacrimal sac plus a large bony ostium, which are the keys to, to a successful outcome. And the problem is if you have a cicatrice lacrimal sac, the problem is you cannot suture it. And as such, it will be really very difficult because you cannot, you can produce a wide marsupialization, but unfortunately you cannot suture the flap because you have only a very minimal small amount of posterior flap. I've seen, other surgeons, what they do is they try to, fix the flap with a fibrin glue and in order to, to produce a intranasal ostium which will not close. And then, of course, a large bony ostium, which are able to address just with the use of your, Kerrison punch. And then, so those are my concern. I mean, may I ask you how much is your success rate when it comes to dealing with cicatrice flaps or, let's say, contracted sac?
Dr. Hawate, when they have the very thick scar tissue, in the first 10 years of my practice, I had a lot of fail because I did not realize that how big the nasal ostium I should get. And second, sometime in the beginning of my practice, I did not try to make the very well approximation of the flap. So in the first part of my practice, I have about 10% of the fail. But when I try to introduce the concept of the bone and the concept of the flap in the past 8 years, I haven't seen my fail case. And one case that I did with the good bone, and I did very good surgery, and the patient is an international patient. He came from the Africa and get the surgery with me, and he came back by 2 weeks after the surgery, and he came back again by 6 months. But in that case, is one case that I got the failure from my surgery because of no good post-operative follow-up and no good for the cleaning of the nasal cavity. And when I have found that they have the chronic infection in the like granulation with the bacteria when he came back at 6 months, and that initiate the cicatricial encroaching to the ostium that we have done very good during, even though we have done very good job during the operation. I think the part of the follow-up is so important also, because if we do the good job but we did not follow up patient properly, sometimes it only minimal the nasal clot or nasal discharge can initiate the fungus or the bacterial infection that gonna lead to the abnormal scar tissue.
Yeah, I agree with you. So really, it's follow-up is also very important. Much more so if you are doing recanalization procedures. But of course, I think really the clue to success, because we are aware of the paradox of lacrimal surgery, which was published by Geoffrey Rose, wherein there is a backwash of the secretion, even if there is a patent, intranasal ostium. Nevertheless, I think it's really the elimination of the sac. Elimination of the sac, wide marsupialization, whether you use a fibrin glue or you suture it, that will, be the success or will dictate the success of the procedure. And of course, you've mentioned about the large bony ostium, so you avoid SAM syndrome. So, but again, I would like to congratulate you because your technique of suturing is really very impressive. Yeah, thank you.
Thank you.
I would like to take a question from one of our participants. He mentioned about this. I'm trying to, yeah. It says here, Dr. Natawood, nice to hear from you again.
Right, sir.
Could you share the name of application about study of the bones in endoscopic DCR you are showing?
The name of the application. The name of the application, right? The name of the application, right?
Yes, that's right.
You can download in the Apple Store. It's named Anatomy C, and we can buy annually per year. They have like a student version, professional version, and advanced version, and you can use in the any iPad. If you have iPad, you can open and use this one to show the patient, and I think you can record that one, and you can apply this one for your talk, and you can let the resident keep practice and do the surgery, even though going to be eyelid surgery, external DCR, endonasal, or even though orbital surgery by digital dissection. I think it's very, very helpful for learning.
No, thank you very much. That was fantastic.
May I ask a question to Dr. Natawat?
Sir, yes, please. Nice to meet you, sir, Dr. Cover.
First of all, admiration for the quality of your surgery. I've hardly seen anybody do a bimanual procedure in the nose so beautifully and do such wonderful suturing. I enjoyed watching you some 3 decades ago when you came for one of our earliest oculoplastic meetings and showed the flaps so beautifully. My questions was, are there situations where you prefer to do an external DCR rather than an endonasal DCR? Say, for example, a traumatic nasolacrimal duct obstruction with a lot of bony deformity as well, or pediatric cases, or how do you prefer to do them?
Oh, honestly, for the past 16 years, I have never done the external DCR anymore. I try to keep our use endoscopic in every case of my DCR surgery. Even though I have the difficult time for the marked septal deviation, I have the technique that I use to. I did not do the septal deviation surgery. I just use the fear to put the septal that deviated away. And sometimes I use a cotton chip and cotton ball in the small and put in the uppermost of the nasal cavity, just a few millimeters that I can have the more space that allow me to do the surgery. But that case, that sometimes they have bleeding a lot, so we just pack it and repack it and repack it. That's my technique. I got the try to do 100% of the endoscopic DCR, and I think I can suture. I try to suture in every case, and if I have the traumatic case and have the like inferior orbital rim or frontal process fracture and displacement, I would ask the patient to do the CT scan first. And in some condition that the bone deviates so much and they have the like displacement of the bone and the frontal process displaced and very thick scar tissue happen, I will use a CT to put in the application name HOROS, HOROS, and you can edit your own in the computer Macintosh, Apple, and you can like to digital 3D and you can manually study about the 3D bone. And then I found that it's so thick, I would use the retinal light pipe to put from the punctum to see and locate the area of the thick bone, and I would try to remove the thick bone as much as possible. That's my technique, and I never done the external DCR for at all. And last question for the pediatric DCR, I will wait the patient until at least 3 years old to have the nasal cavity big enough and the head is big enough, and then I start to do the endoscopic DCR in the kid that more than 3 years old. 2 years old may be too small. I may try to do the stent and popping and restent.
Thank
Dr.
you.
Latout, I have a comment that you have once again proven that you are fantastic endoscopic dactyl surgeon of the region. And I got the opportunity to learn from Dr. Latout in 2008 endoscopic DCR and bring the endoscopic DCR technique in Nepal. And since then we have practicing that and spreading among our colleagues here. And I remember that instead of doing the septoplasty, you used to do septal fracture with the fear, just push forcefully the septum to the another side and make a space. And it is a good technique, and you can do that for several times if disturbing your space at the time. My question to you that in the scar tissue management, what is the experience of mitomycin C using to manage the scar tissue to make the successful DCR during your revision?
Yeah. Yes, that's a good question. On the beginning of my practice around 2006, 7, 8, I have some complication from the scar tissue. And that moment I have tried the mitomycin C for a while, but my concept of the bone and the flap not that good yet. So even though I have tried to use a mitomycin C, I have found that some care, I still got the failure from, even though I tried to use a very good mitosensitivity. So after 2008 or 9, I stopped using mitosensitivity at all. And personally, I do believe about the successful of the anatomical success more than the chemical agent. So, and in some condition that the patient have the really bad scar tissue in the common canaliculi, I use some mitomycin C also. But if you use mitomycin C more than concentration too much, it's gonna be necrosis and need to be really, really careful. And I think we will talk this one in the fail DCR.
Well, I think, yeah, I think with the comment of Dr. Grober, I think, I've done, endoscopic DCR for quite a long time. And, at present, I have completely shifted to, transcanalicular. But, at times, I really have to do external. Why do I prefer external over the endonasal DCR? The reason is that, I don't like to use powered instrumentation such as drills, which actually is very, very helpful when you do endoscopic DCR. Because with the use of your Kerrison pumps, sometimes it takes, a bit difficult to remove that anterior frontal process of the maxilla, which is the anterior 1/3. So I think, but of course, each of us surgeon has its own, preference and what you have practiced for many, many years. I think that's the one that, and if you're getting good results, you should stick to it. So,
Thank you, Professor Havati, Professor Grover, Dr. Nathod, and Professor Saizu. We have had a very nice discussion here.